Good morning, everybody. Thank you so much for joining us in this lovely October morning. My name is Dr. Andrew Srisuwana-Newcorn from The Ohio State University, and it's my pleasure to chair today's webinar from Cancer Grace, the 2025 edition of the Blood Cancers OncTalk live webinar. We have an action-packed schedule from accomplished, very, very well accomplished physicians from all across the country, and we'll be talking about acute leukemia, multiple myeloma, lymphomas, as well as emerging cell therapies that could be very, very helpful for various different hematologic malignancies. So stay tuned. We have a lot to talk about today. There will be a session for questions and answers. The questions and answers will be reserved for the end of the webinar at about 1 p.m. or so. So I'll be sharing those questions and then asking them to the experts. There will be some panel discussions between myself and the experts' physicians as well too, in between some of these presentations. So finally, I wanted to thank our sponsors for today's session, Lilly Oncology, AbbVie, and Bristol Myers Squibb. We're greatly appreciative. Without their support, we wouldn't be able to do this presentation for all of you today. So without further ado, I'd like to introduce our first speaker, Dr. Ashwin Kishtagari. So Dr. Kishtagari is a close friend of mine. Dr. Kishtagari is an assistant professor of medicine and hematology and oncology at Vanderbilt University Medical Center. He's a board-certified hem-onc doctor and an expert in treating all sorts of myeloid neoplasms, including myeloproliferative neoplasms, myelodysplastic syndromes, and acute myeloid leukemia. He's passionate clinical and translational investigator, and the combination of passion for caring for patients and pursuing a keen interest in clinical and translational research really drives his desire to be in hematology and oncology. His love for science has always been rooted in the belief that knowledge gained in the scientific arena can translate into better medical treatments and meaningful outcomes for patients. So, Dr. Kishtagari, we look forward to your presentation about acute leukemia and myelodysplastic syndrome. So feel free to take it away and share your screen. Thank you.
Thank you, Andrew, for the kind introduction, and thank you for having me as one of the presenters. Hello, everyone. Can everyone see my screen?
Yes.
Okay. Thank you. It's great to be here today. I title my presentation as "Do I have a bad blood?" This is a common question I always encounter when I see a patient with myelodysplastic or acute myeloid leukemia or a precursor condition called clonal hematopoiesis of indeterminate potential. We have a clinic at Vanderbilt Cancer Center where we see a precursor condition called CHIP as well, where we are trying to understand how we can prevent development of myelodysplastic syndrome or acute myeloid leukemia in some of the patients. So today I'm going to focus my discussion mostly on the precursor condition as well as myelodysplastic syndrome, which is the CHIP can progress into myelodysplastic syndrome. And I will talk about some of the treatment options in myelodysplastic syndrome. Okay. These are my disclosures. I work very closely with pharma companies in developing some of the drugs. Along with that, I also co-host a podcast called Blood Cancer Talks, where we talk about everything related to blood cancer drug development and new treatments available, as well as some of the nuances in treating patients with blood cancers. So to start with, I will talk about clonal hematopoiesis, what it is, and how it is defined, as well as what it means for a patient. So clonal hematopoiesis, it is defined as the expansion of a mutant, somatic mutant, in the blood stem cells. So I want you to think of it as like a typo in your blood stem cells, and that typo over the period of time expands into expands into a clone, and that can potentially have downstream consequences. It is a natural part of aging, because as we age, we tend to make our blood stem cells tend to make mistakes, and that can propagate into development of a disease. So this was first described back in 2014. A series of publications that were published describe this entity, and it as you can see in the slide here, it's reported in about 1% in the patients who are at 60 years of age, and with age it goes up as well. The prevalence 10%, 70, and 30% in more than 90. So it's quite common, but there is a clear-cut definition that emerged after this initial publications that were came out, and the clear-cut definition now it is called as clonal hematopoiesis of indeterminate potential, and they put the threshold of this mutation at 2%, means roughly 4% of your blood stem cells, if they have a particular mutation, and then that is called as clonal hematopoiesis of indeterminate potential. So these are the mutations which are normally seen in patients with myelodysplastic syndrome. We are able to detect this much earlier, before they develop any kind of cytopenias. And these are the common mutations we also seen in myelodysplastic syndrome as well as acute myeloid leukemia. So what it means? So this entity, the clonal hematopoiesis of indeterminate potential, prevalence increases with age. What we have seen is that patients with who have this mutation, who do not have any kind of blood count abnormalities, can still have a worse prognosis. In other words, they can have increased mortality from other conditions as well, and that is something that has emerged after this initial literature was published back in 2014. As you can clearly see that in patients who are older than 70, if they have a mutation, they have worse prognosis compared to patients who do not have this mutation. And what was one of the main reason which surprised a lot of us, that chip not only increases the risk of blood cancer but can also increase the risk of cardiovascular mortality, which was a big surprise. And right now at Vanderbilt, we work very closely with our cardiologists in accurately risk stratifying patients with these mutations when they present to our clinic, to see how we can address the other modifiable risk factors for cardiovascular disease, such as high blood pressure, diabetes, or cholesterol, so that we can potentially mitigate some of the risks that develops because of the presence of these somatic mutations. And along with the development of the cardiovascular risk, there is a risk of blood cancers as well. It is not huge, as you can see in the slide here. And in the big studies that were published, the risk is very minimal, about 1 to 10%, based on various risk factors, are at risk of progressing into blood cancers. And to accurately risk stratify, there is a scoring system right now that has been developed, and this is something we routinely employ in our clinic when we see a patient with this somatic mutation present to the clinic. We look at all these various variables, age being one of the factor as well, and then we look at the other predictor variables, such as the presence of DNMT3 mutation or high risk mutation, and the number of mutation also is very important, along with what fraction of the stem cells in the bone marrow have this mutation is also equally important, along with the what kind of blood count abnormalities they have. With all these variables, we are able to accurately risk stratify the patients into high risk, intermediate risk, and low risk. These risk means that these are at risk of progressing into a blood cancer. Now, moving on to the next part of my presentation, I want to talk about myelodysplastic syndrome. So, patients with clonal hematopoiesis, which is the somatic mutations in your bone marrow, they can progress into myelodysplastic syndrome. So, myelodysplastic syndrome, I hear a lot of terminologies when I see patients with myelodysplastic syndrome. Some patients describe or they were told that their bone marrow is dysfunctional or their bone marrow is failed, and that's why they developed this condition. There are a lot of confusion as well, because historically it was named as myelodysplastic syndromes, but most recently the WHO has actually reclassified it as myelodysplastic neoplasms instead of syndromes, because I think it is an accurate capture, because at the end of the day it is a clonal process, means that it is driven by a genetic mutation, whether it is a somatic, that is something that happens with aging, or it is sometimes can you're born with the somatic mutation, what we call a germline mutation. So I think the reclassification into a myelodysplastic neoplasm is an accurate representation. And what we see and the way we diagnose myelodysplastic neoplasms is presence of something called morphologic dysplasia, which is nothing but the cells look different than normal, or otherwise called as a funny looking cells under the microscope, and that can cause impaired blood production, including anemia, thrombocytopenia, or neutropenia. In other words, a low hemoglobin, low platelet count, as well as low neutrophil count, which can put you at risk of development of symptoms of shortness of breath. When you have low hemoglobin, when you have low platelet count, you can are at risk of development of bleeding, and when you have low neutrophils, you are at risk of development of infections. And then we, along with the looking under the microscope, we also look into some of the genomic markers in order to guide both prognosticating the patients as well as risk stratifying the patients, because it has therapeutic implications down the line. And there are two ways we capture the genomic heterogeneity in myelodysplastic neoplasms. One being is something called karyotypic abnormalities, as shown in the slide here. These are the chromosomal changes which sometimes guide in treatment decision. And the other thing we include is the genomic abnormalities. These are the same genetic mutations which we see in patients with clonal hematopoiesis. So the epidemiology of MDS, it has been a challenging to accurately estimate the prevalence of MDS, because historically, MDS was not even captured. A lot of the times, patients who had unexplained anemia, they were given iron supplementation and were just monitored. But most recently, with the advent of genomic testing, we are seeing more and more patients with myelodysplastic syndrome being diagnosed, as well as we have a lot of newer therapies as well. So I think with that advent of genomic testing, there is a lot of patients who are being diagnosed with myelodysplastic syndrome historically were misclassified. So, as I alluded earlier, there can be inherited genomic abnormalities as well, which is something you are born with, and that can predispose you to development of blood cancers such as myelodysplastic syndrome, or the mutations are something you are acquire as you age. And there are a specific category of inherited mutation called DDX41, which can predispose you to development of myelodysplastic syndrome in later part of the age, like mostly patients present when they are more than 60 years, they are at risk of development of MDS. So then the next question is, once we make the diagnosis of MDS, Then the question comes is the prognostication, how we risk stratify patients. So we had various scoring systems. Historically, something called revised international prognostic scoring system, which we used to include the blood count abnormalities. Along with that, the some of the genomic testing, mostly the chromosomal changes, but that has evolved into incorporation of molecular abnormalities as well, which actually accurately capture the genomic heterogeneity as well as stratify patients because it has therapeutic implications down the line. So as you see, some patients with international IPSSM, which captures the molecular mutations along with the blood count abnormalities and the chromosomal changes, can upstage a patient who is historically thought to have low risk into a high risk category, and vice versa as well. Sometimes patients were captured as high risk, but with their molecular mutations, they can be downstaged into low risk as well. So this has as I mentioned, this has therapeutic implications. As you can see in the slide here, so it can guide you in terms of deciding whether the patient needs to be referred for a bone marrow transplant or not, because only with high risk MDS we recommend bone marrow transplant if they are eligible in the sense that, if they're less than 80. We have at Vanderbilt, we have transplanted patients who are in their late 70s as well, if they have a good performance status and no comorbidities. And we just do not take one particular age cutoff in determining their transplant candidacy. We take both the comorbidities, the performance status as well in taking into consideration. So every high risk MDS patients, if they are eligible, needs to be at least evaluated by a transplant team to determine their transplant candidacy, because that is the only curative therapy today available for patients with high risk myelodysplastic syndrome. And then low risk MDS, we'll talk about what are the treatment options available for these patients. So talking more about the treatment options for MDS, I'm going to broadly talk about what are the available treatments we have. So before we talk about it, I just want to start with a question, which is very important, because this has changed how we treat low risk MDS especially. So this is a patient who is 70-year-old who presented with anemia, had a normal platelet count and normal neutrophil counts. But when they had evaluation done for this anemia, they were found to have this ring sideroblast. These are the bone marrow cells, and you can see that there are this ring around the nucleus, and we call them as ring sideroblast, and they had this mutation called SF3B1. With right now there is an approved treatment for these patients, and that is luspatercept, which has changed how we treat patients with low risk MDS in presence of ring sideroblast. So this is how I treat low risk MDS in 2025. Majority of the times it is determined what blood count abnormality the patient has. If they have a low hemoglobin and they have a genomic abnormality called deletion 5q, I choose something called Revlimid. And if they have a genomic abnormality SF3B1 or ring sideroblast, I go with luspatercept as a first line treatment option. And if they do not have any of these genomic abnormality and the EPO level is less than 200 and they are not heavily transfusion dependent, I go with something called erythropoietin stimulating agents. And if they progress on these, then the next option, which is most recently FDA approved, called imtelostat, a telomerase inhibitor. Once they progress through all these agents, the next option is hypomethylating agents such as azacitidine or decitabine, which is actually FDA approved for high risk MDS. There is a minor subgroup of low risk MDS patients called hypoplastic MDS. These are the patients who tend to have cytopenias, and their bone marrow is also what we call hypocellular, means less cells in the bone marrow. They tend to respond with immunosuppressive therapy. And as I mentioned, majority of the treatment decisions we make in the low risk MDS is based on the blood count abnormalities. So if they have low platelets, then we go with something called TPO agonist. There are two agents. One is called romiplastim, other is called L-trombopac. And if they have low neutrophil counts, then we choose based on the genomic abnormalities they have. If they have a particular somatic mutation such as IDH1, IDH2, they have a particular inhibitors targeting small molecule inhibitors targeting these mutations, but these are only minor subsets. Majority of patients, if they have neutropenia, end up getting azacitidine or decitabine. And now, briefly talking about high risk MDS, we were fortunate we have so many agents in low risk MDS, but I cannot say the same thing in high risk MDS. We unfortunately are very limited by the treatment options we can offer our patients, and that is the reason why I encourage all my patients with high risk MDS. The first line option is to be participating in clinical trial so that we can develop better drugs for our patients. But if in absence of clinical trial eligibility, some of the treatment options we have is hypomethylating agents. Azacitidine or decitabine could be a good treatment option in terms of improving the blood counts, as well as preventing the progression to acute myeloid leukemia, as well as making them a good candidate for allogeneic stem cell transplant. If they have a somatic mutation, still the IDH inhibitors could be a good option. There was historically a lot of interest in adding something called venetoclax to decitabine. Venetoclax is a BCL2 inhibitor studied well in acute myeloid leukemia. We could potentially utilize that even in high risk MDS, but the phase 3 clinical trial was just reported few months ago, and which was actually a negative clinical trial. But there's a lot of discussion right now ongoing that there might be a subcategory of high risk MDS who might benefit from venetoclax treatment. I think that is still ongoing discussion right now. I want to briefly touch on two things. One is the Vexus syndrome. This is a recently described entity, and patients with this syndrome who have this classic something called vacuoles in the bone marrow, followed by E1 enzyme. X-linked means that the mutation they have is X-linked, and they have lot of rheumatologic symptoms like bone pains, joint pains, and they have the somatic mutation in something called UBA1. And almost all the patients with Vexus syndrome are male. There are very few isolated reported cases of females, but almost all of them are male. And these patients present with low blood counts, and they can also progress to myelodysplastic syndrome. It's a recently described entity. Right now, we are treating these patients as MDS patients and using hypermethylating agents to treat these patients. And if they are eligible, we are taking them to allogeneic stem cell transplant. But there are right now a lot of clinical trials ongoing in developing new drugs for these patients. Lastly, I want to describe about one entity called MDS-MPN overlap syndrome. As I talked earlier, in myelodysplastic syndrome, majority of the patients present with cytopenias, but MDS-MPN overlap syndromes, sometimes the patient can present with high blood counts as well, and they tend to have symptoms of something called myeloproliferative neoplasms with enlarged spleen, and a lot of constitutional symptoms. This is a rare subtype with no clear treatment defined at this moment right now. And we borrow a lot of treatments from myelodysplastic syndrome as well as myeloproliferative neoplasms. There are right now a lot of dedicated clinical trials to develop new treatments for this entity, which is a huge unmet need in my opinion. So to conclude, I want to highlight few take-home messages. I think one thing is fatigue could indicate low blood counts, and I think that needs to be evaluated. And multiple studies in myelodysplastic syndrome have shown, especially low risk MDS, that low red blood cells can negatively impact the quality of life and activities of daily living, and can also have a decreased survival as well. And other thing which has highlighted earlier, the prevalence of chip, which is almost close to 10% in patients who are more than 70, and that needs to be evaluated, and needs to be monitored very closely, because it not only increases your risk of development of blood cancers, can also put you at risk of cardiovascular disease as well. Another thing is, it is very important to we right now have multiple treatment options for low risk MDS. We have in the past 5 years we have three new treatments for myelodysplastic syndrome in especially in the low risk MDS. I think it is important to be evaluated at a tertiary cancer center if you have a high risk MDS. Given the limited treatment options available, I think I highly encourage to participate in clinical trials in high risk MDS. Given the limited treatment options, we need to develop better drugs in that setting, as well as I want to highlight about the transplant consideration. Age should not be the only factor. We need to take both the comorbidities as well as the performance status in determining the transplant candidacy. Thank you so much for listening to my talk. I'm going to hand it over to Andrew.
Thank you so much, Dr. Kishtagari. What a complicated topic to explain, CHIP and MDS. I know that always brings a lot of questions and patient encounters, and also a very challenging disease to treat as well. So thank you for that broad overview. I know you have to go, and for the audience, Dr. Kishtagari is unable to stay for the panel discussion, the Q&A. I didn't mention that I'm also a leukemia doctor and treat myeloid neoplasm, so I will fill in for the question and answers for Dr. Kishtagari. So thank you again. We very much appreciate your time. All right, have a great day. So moving forward, we are looking forward to our next talk by Dr. Jennifer Cooper-Ryder. So Dr. Cooper-Ryder received her medical degree at OSU, where I'm currently at, so go Buckeyes. She completed her chief residency and her fellowship at University of Chicago. And after her fellowship, she joined as faculty at the same place, University of Chicago, as an assistant professor, focusing on treating multiple myeloma and other related plasma cell disorders. She has a particular interest in clinical investigation and translational correlates, elucidating the risks and benefits of long-term therapies in multiple myeloma. So without further ado, please take it away, Dr. Cooper-Ryder.
Thank you so much for that introduction. I am going to work on sharing my screen here in just a minute. All right. And can everyone see my screen?
Yep, it looks good.
Fantastic. Thank you. So thank you for that introduction and for inviting me to be here today. I'll be giving a multiple myeloma primer, so an overview of really what myeloma is and the current state of treatment right now. So what is multiple myeloma? So multiple myeloma is a cancer of plasma cells which live in the bone marrow. The plasma cells are a normal part of the immune system, and when they are mutated and when they're growing abnormally, that can be multiple myeloma. It doesn't have a useful name like lung cancer that tells you exactly which cell is the cell of origin, but despite the name, it's a cancer of plasma cells. Oh, there's my disclosure slide. My spouse is employed by AbbVie. So multiple myeloma, in the healthy bone marrow, there are plasma cells there. They're a normal part of the immune system, and they produce normal antibodies, which are responsible for fighting infection. But when these cells grow abnormally and multiply and grow too much, They produce abnormal antibodies that cause the body harm. And we'll talk about what that is in just a minute. But just a little bit of vocabulary related to multiple myeloma. An antibody is also known as an immunoglobulin. So if you see those words, they're interchangeable. And there are two main parts to the antibody, the heavy chain, which is noted here in blue, and the light chain, which is in orange. And this is a protein that's produced by the plasma cells. And as I said, the normal role is to fight infections. But in myeloma, they're not going out and fighting infections. They're causing harm to the body. And sometimes the level of the proteins is called the myeloma protein. It's measured by the M spike. And so those are some words that you might see as you're reading more about multiple myeloma. Multiple myeloma is the second most common cancer of the blood. It's less than 2% of all cancer cases in the United States. There's about 30,000 new cases per year, at least there was in 2018. And over 118,000 patients who are living with the disease. The myeloma is most frequently diagnosed in patients aged 65 to 74, and the median age of diagnosis is 69. And so patients, this is not something we generally see in pediatric populations. So what happens when you have multiple myeloma? So there are symptoms that we associate with active multiple myeloma disease, and the affected parts of the body are often the bones, the kidneys, and the blood. And in the bones, myeloma can interfere with the cells that keep bones strong and lead to normal bone regeneration. And because they interfere with those cells, they can cause thinning of the bone or holes in the bones that can actually lead to bone fractures, which can be painful for patients and limit function. It can also, the same mechanism can actually increase the calcium in the blood. That can lead to constipation and fatigue, but when it's severe, it can also lead to confusion, to seizures, and even to heart issues. And so that can actually be a reason why patients will present to the hospital. The kidneys can also be affected. So myeloma proteins can interfere with the normal filtration of the blood by the kidneys, and this can eventually lead to kidney damage over time, and in some cases even cause kidney failure. And so our goal when we're trying to detect and treat myeloma early is to prevent severe kidney damage that could ultimately result in kidney failure. And finally, myeloma cells also, as they're growing in the bone marrow, which is the factory for normal blood cells, and they can crowd and interfere with normal blood cell production, which can lead to low blood cell counts. So that can increase the risk for infection, fatigue, bleeding, and particularly anemia. Myeloma can present with anemia. And so when we have those together, we call that the CRAB criteria of myeloma, which is an abbreviation for hypercalcemia, so an increased calcium level, that's the C. The R is renal or kidney dysfunction. The A is anemia or low red blood cell counts. And B is for bone lesions. And so those are the things we're really looking for when we're trying to diagnose someone with myeloma. Now, this graphic shows the natural course of multiple myeloma. And so often myeloma actually arises from an asymptomatic precursor condition. Dr. Kishtagari was talking about clonal hematopoiesis or CHIP being a precursor condition. And in the case of myeloma, that is MGUS or monoclonal gammopathy of undetermined significance. And again, this is an asymptomatic precursor disease which is characterized by a low tumor burden. So the M protein, the protein amount that's produced by the myeloma, is low, less than 3 grams per deciliter. And the percentage of plasma cells that are abnormal in the bone marrow are less than 10%. So not a lot of protein or disease in the bone marrow. The risk of progression to symptomatic myeloma is about 1% per year in the MGUS population, so relatively low, but should be tracked over time. Once the tumor burden crosses a certain threshold, so an M protein of more than 3 or bone marrow plasma cells of between 10 and 60%, we call that smoldering multiple myeloma, which is abbreviated here with SMM. And in those patients, because the disease burden is higher, there is a higher risk of progression to symptomatic myeloma. That percentage is about 10% per year in the first 5 years of a patient's smoldering diagnosis, 3% per year for the next 5 years, and then 1% per year thereafter. And so really what that means is the longer that patients have stability of their protein levels and their disease with smoldering myeloma, the less likely it is to progress to active disease. Not everyone progresses to active myeloma that has symptoms, but it is something that we watch carefully for because we don't want to end up with any of those complications like bone fractures or kidney dysfunction. Symptomatic myeloma is diagnosed when patients develop one of those myeloma defining events, which are the CRAB criteria, or if they have greater than 60% disease in their bone marrow or significantly elevated light chain. So if that protein level, the light chain level gets above a certain point, then that's also consistent with myeloma that requires treatment. And we'll talk about what we use for treatment in a minute, but the goal is to really bring those levels of disease down to negative, down to 0 if we can, into a remission. Unfortunately, at this time, we're not considering myeloma a curable disease. Now, that may not be true for some individuals. It may actually be curable, but in most cases, the disease tends to come back even if we achieve a remission at first. So then if the disease starts to come back up with an increasing number of those plasma cells and an increase in the protein level, we change the treatment that we use to try to bring the disease back down into a second remission. And if it comes back again, we do the same. And so the remissions tend to get shorter with time, although that's changing now in the era of sort of modern immunotherapies. We use multiple different tests together to diagnose and track multiple myeloma. So we use a combination of blood tests, urine tests, imaging, and the bone marrow biopsy. When we do blood tests, we're looking at really tracking the abnormal protein in the blood over time. So if we're treating a patient, we're looking for those to come down. If we're monitoring a precursor state, we're looking at whether those are progressing over time. And we use the SPEP, or the serum protein electrophoresis, to give us the amount of abnormal protein, which is called the M spike, immunofixation to tell us the type of abnormal protein. We look at quantitative immunoglobulins, which give us the amount of total antibodies, both normal and abnormal, and that has a fast turnaround. So it's kind of a quick and dirty way for us to assess the protein levels. And the serum-free light chains, which track that smaller portion of the antibody over time. And actually 15% of patients do not have an increase in their total antibody, but they just have an increase in that light chain. So it's another important thing to track for many patients. We use other labs that provide information on staging and tumor activity, as well as the blood cell counts over time and the organ function, including the kidney function and the calcium levels, to tell us whether these things are changing over time. We also use urine tests. The urine protein electrophoresis, for example, tracks the abnormal amount of protein in the urine to determine if the protein is coming through the kidneys into the urine. We use imaging, which can show us bone involvement or activity of tumors or lesions. We usually use a PET CT scan or an MRI because those allow us to track the tumor activity over time. So again, with treatment, we can see if those are improving, or we can see if there's progression of disease on those imaging studies. We also have historically used skeletal surveys, which are an X-ray based technology, and those show us bone lesions, but they don't necessarily show us tumors elsewhere or tumor activity. But sometimes we'll start with that to get a sense of whether the bones are affected by a patient's disease. And finally, the more invasive test, which is the bone marrow biopsy. And even though it's more invasive and requires a bigger ask from the patient, it's still very important to how we can diagnose and track multiple myeloma. So the first thing we do is we use basically the pathologists look under the microscope, or they use flow cytometry, which is laser-based, to quantify the abnormal plasma cells, to give us a number, a percentage of abnormal cells in the bone marrow. And as we talked about, that can dictate actually whether a patient gets treatment or not, and also allows us to see a change and improvement with treatment as well. The bone marrow biopsy also allows us to look for genetic changes in the myeloma cells. And some of these abnormalities will indicate a more aggressive disease. And so we may take a little bit more aggressive approach to certain disease if they have higher risk features. Finally, we can now track MRD, which stands for minimal or measurable residual disease testing. This basically looks at a fingerprint of the myeloma cell, a genetic fingerprint, and we can track that even if there's tiny amounts of myeloma around. And so that allows us to see if there's still trace amounts of myeloma, even despite excellent response to treatment. So we use all of those studies together to tell us, should we treat now or should we wait? When I talked about sort of there's that precursor state versus symptomatic myeloma, we're really trying to determine when the right time is to treat. So we'll start over here with the symptomatic side. So in the red box, These, again, are patients who have myeloma-defining events as defined by the CRAB criteria, or increased plasma cells above 60%, or light chains that have a ratio of greater than 100. And so those are patients who are counted as having kind of symptomatic myeloma that require treatment. You see that I have the blue box here around the smoldering myeloma population. There is some data now that there are some high-risk smoldering myeloma patients that may benefit from some treatment. And so that's something that if you have been diagnosed with smoldering myeloma, your doctor will talk to you about whether that's, you're in that category or not. But again, we're still monitoring those patients regardless very closely for progression to symptomatic disease. When we talk about treatment in the newly diagnosed myeloma patients, the exact combination of medications depends a little bit on where you are in the world, but usually it's a combination of 3 or 4 medications, depending on your age and your other comorbidities. If you're eligible, we'll consider deepening that response with a stem cell transplant. That's an autologous stem cell transplant, which is different than what we use in myeloma or in leukemia. We use your own stem cells. And that's followed usually by maintenance therapy or long-term therapy. When we're looking at this part, the combination of 3 to 4 medications up front is often called induction therapy. It's not traditional chemotherapy, but they're often targeted agents, which are a combination of an antibody therapy, an immunomodulatory agent, a proteasome inhibitor, and a steroid. So we often use those 4 medications together for 4 to 6, even more potentially months, to induce a response, to get the myeloma tumor burden down. And then we consider deepening that response with something called a stem cell transplant. And this is usually good at sort of increasing the depth of response, meaning getting rid of additional residual disease to prolong the time that a patient's in remission. Now, this is an intense high-dose chemotherapy, which is followed by a dose of the patient's own stem cells. Again, this is an autologous stem cell transplant. Because it's a high-dose chemotherapy, there are a lot of side effects associated with it. Patients are in the hospital. They have severe fatigue and GI side effects, and they have low cell counts, putting them at risk of infections. And so to go through the stem cell transplant, patients must be fit. And each transplant center will have slightly different criteria of who is fit for transplant. And so sometimes ultimately the decision is that a transplant might cause more harm than benefit, but that's a discussion that we're often having with our patients around stem cell transplant. After transplant, or even if the transplant doesn't happen, if a patient elects not to go forward with the transplant, then we go to maintenance therapy, which we consider the long-term therapy. It's usually a combination of an antibody treatment with a pill. The optimal duration is unknown. Right now, we're often treating patients until progression or until they can't tolerate the therapy anymore. But we're getting more data on exactly what the correct or optimal duration for any individual patient might be. We talked about that myeloma is not typically considered curable. And so when it comes back, we have other treatment regimens that we can use. So first, we could use a combination of different treatments from the same drug classes that I talked about before. So we have different agents in those classes that we can rearrange and use. We sometimes can use traditional chemotherapy, which patients respond to. But very excitingly, we've also had approvals of immunotherapies in recent years, including CAR T-cell therapy and bispecific antibody therapies. And these have really improved survival and outcomes for myeloma patients. I'll briefly talk about CAR T-cell therapy. We'll hear more about these a little bit later in the program today. But CAR T-cell therapy stands for chimeric antigen receptor T-cell therapy. What these are that we engineer a patient's own T-cells to be able to recognize a target on the myeloma cell so that when we give those cells back, they can target and kill the myeloma cells. The T-cells are part of the normal immune system. There are 2 currently approved products in myeloma. They both target the same thing on the surface of the myeloma cell, which is B-cell maturation antigen, BCMA. And the 2 products are ide-cel and cilta-cel. And there's been a lot of press around these agents recently because in cilta-cel, there was recently 5-year follow-up data shown that showed actually that 1/3 of patients in 5 years still have not had a relapse of their disease. So this is really exciting, especially in relapsed and refractory patients. There are also other products and other targets under investigation. So both of the currently approved agents target BCMA. There are other BCMA targeting CAR T cell products that are in development, but there are others that target other surface proteins on the myeloma as well, some that target multiple surface antigens. And so we're really excited about products that are going to continue to come out, hopefully, and continue to improve patient outcomes. Again, we'll hear more about CAR T later, but just from the patient standpoint, what is involved with CAR T cell therapy? If patients are eligible, then we have apheresis of their T cells, so collection of those T cells. Those are then sent to the company for manufacturing. The times vary. And during that time, often patients are restarted on myeloma-directed therapy to control their disease while the CAR T cells are manufactured. They're then sent back. We give patients low doses of chemotherapy with lymphodepletion, basically to decrease the amount of T cells in the patient's body to make room for the CAR T cells to become dominant. We then give the CAR T cells and then monitor in the hospital at our center. Sometimes they can be given outpatient, but usually inpatient, monitored for short-term and then subsequently long-term toxicities from the CAR T. There are also another type of immunotherapy that have been approved recently in myeloma called bispecific antibodies. They're currently approved. There are actually 4 currently approved products. The ones that are approved are in bold here. The way that these work is that this is actually a therapeutic antibody, and one arm target actually sticks to the myeloma cell, to a protein on the myeloma cell surface. The other binds to a T cell, and it brings them together so that the T cell, which is an immune cell, can kill the myeloma cells. And as I said, there are 4 approved products, 3 of which target BCMA, B cell maturation antigen, and 1 talquetamab that targets GPRC5D. Right now, these are currently approved for 4 or more lines of therapy in myeloma, so later lines with patients that have refractory or relapsed disease. But they are again being investigated in earlier lines of therapy in combination. There are now tri-specific antibodies that target multiple cell surface proteins, and all of these things are under investigation. So we're really, again, very excited to see what's going to come with bispecific antibodies and how we can continue to improve outcomes for our patients. I want to conclude with this slide about prognosis. And so what I want to point out is the 5-year survival in myeloma is about 62.4%. But as you can see, this is older data. This is from 2015 to 2021. So this is data from before the advent of any of the immunotherapies that we're currently using in myeloma. So what I really want people to leave with is that, myeloma, while it's not curable, is treatable over many years with therapies that are generally very tolerable. And so what our goal will continue to be in myeloma is to improve not only quantity of life to keep patients living longer, but also to improve quality, right? So to make all of those therapies that we're using to decrease the long-term toxicity of those and keep patients living well for their additional years. As you can see here in this chart on the right, the deaths related to myeloma have been decreasing since the 90s. And so again, we're working very hard to continue to improve those outcomes. And so with that, I will pause and we'll continue with the program.
Amazing presentation, Dr. Cooper-Ryder. Thank you so much for explaining multiple myeloma to the audience. It is a very confusing topic. So we will move forward to the panel discussion with myself and Dr. Cooper-Ryder talking about the past 2 presentations regarding CHIP, MDS, AML, as well as multiple myeloma. I will cut this panel discussion short so that we stay on time for the noon presentation for lymphomas. So I will be both chair and discussion panelist, so this will be a little bit tricky, but I've got a lot to say. I can't ask Dr. Kishtagari, but I have some comments to make about this entire process. I want to commend you and Dr. Kishtagari for kind of showing the natural history of these diseases. And you point out, there are precursor conditions, MGUS for multiple myeloma, CHIP in clonal hematopoiesis in AML. CHIP goes to MDS, goes to AML. MGUS goes to smoldering, goes to multiple myeloma. And I think that's really a great framework to think about it, because I truly have a lot of challenge explaining what these diseases are to patients. And I think that saying it as a phase makes much more intuitive sense. One question I get a lot, and I wonder what you think about this, is how do I get this disease? Why do I have it? What do you say to that?
Yeah, my answer, so multiple myeloma again is generally not a disease we see in pediatric patients, right? So there is something associated with age and exposure that seems to be related to the advent of multiple myeloma. We don't know exactly what that is. There's no clear, obvious exposure that we've tied as clearly as have been in other malignancies, right? So, for example, with smoking and lung cancer, we don't have anything that's as closely tied. And so when patients ask me that question, often I say it's a combination of things, most likely. There may be a genetic component. So there are some myelomas that probably are associated with something inherited from the parents, something with the environment or exposures over time, and then just bad luck, right? So ultimately, this is a genetic defect in a cell that's caused them to grow abnormally. And ultimately, there's not something that we can look back on and say, if I had just changed this would have changed my outcome. I think that, in general, patients can beat themselves up as they try to think about, what might have caused their risk to go up. And really, I think at the end of the day, we don't totally understand what causes it. And ultimately, our goal is to try to treat it as quickly as possible, as quickly as we need to, right, in order to prevent the complications. But the short answer probably is, we don't totally know, but it's probably a combination of factors.
Yeah, and I totally agree with that. And I do emphasize that last part of kind of random chance, especially as, like you said, genetic mutations, they definitely happen. I mean, you and I probably have CHIP, we
Yep.
just don't know it. I do tell patients that there was a really interesting article that said CHIP can happen in utero even, and we just never knew. So we've been getting really good at detecting these things, and they may never manifest. So it is just random luck as not only just getting the mutation or getting the precursor, but if the precursor actually becomes relevant, because it never may. You could have the precursor for the rest of your life, and it doesn't really harm you. You can live without any notice. Yeah, and I think the majority of patients probably do.
Yeah. And lots of patients ask me, have I had this for a long time? And often when we look back, we do see maybe some elevated protein levels for a long time, but it never caused patients any trouble, right? And so often that it has been there for many years, and in, most patients, it doesn't ever become a problem.
Yeah, and I get a lot of anxiety with that kind of thought process, and I try as hard as I can to say, a lot of people probably have been living with it without even knowing.
Exactly.
So another thing that I wanted to comment on is the very stark difference between the two presentations. I wish that you and Dr. Kishigari were able to show a timeline of the FDA-approved therapies in both conditions. And just for the audience, it is starkly different. I don't treat multiple myeloma, but I feel strongly that I see a new groundbreaking therapy that gets approved almost every single year. It's quite incredible. And, like Dr. Kishkari was saying, we only have maybe 1, 2 lines of therapy before we really highly consider very strongly a clinical trial. But Dr. Cooperrider, I mean, first question is, how many lines of therapy is common in your practice? And then number two, philosophically, there's no right answer to this, but why do you think that there's so many successes in multiple myeloma compared to, my disease specialty like acute myeloid leukemia?
Yeah. I mean, I think to answer the first part of your question, we're so excited to have these approvals, and as you said, it's rapidly changing. As for why myeloma is I think it's, more lymphoma and myeloma tend to be more mature neoplasm. So the cell of origin is a more mature immune cell. And it seems to be more receptive to some of these targeted therapies. So CAR T cell therapies now are also being used in ALL as well. So some leukemia, but have used them now in leukemia, in lymphoma and myeloma for many years successfully. And so, I don't know exactly why these are more treatable, right? The cell of origin seems to just be more receptive to some of these types of therapies, um, but ultimately, we're very excited. We just had another approval, belantamab mafodotin, which is an ADC, was approved. So you're right, the timelines have been really different.
It's really hard to keep up with multiple myeloma.
Yeah, no, it is. And you asked how many lines of therapy is common. I mean, we have patients who have lived decades with this disease, right? And so often we will go through 10 or 11 lines of therapy, which I think, it sounds like so many, right? And it is, which is actually, but to have 10 or 11 lines of therapy is really, it's really a fortunate time. This was not the case 20 years ago.
Right. And just for the audience, like 10 to 11 lines of therapy is kind of shocking to hear for me. When we're treating acute leukemia and we're doing much, much less than that prior to getting into a clinical trial. So it's amazing progress. And I guess my last question is another philosophical one for you in the multiple myeloma field, because I read some maybe opinion pieces about this word cure in multiple myeloma. And you mentioned, this is not a curable disease, but the opinion pieces I read is very provocative. And should we be redefining the word cure, particularly because of what you said, is that these patients are living decades on 10 plus lines of therapies? I mean, I guess, do you have any thoughts about that? And do you see in your practice that patients are passing away from something completely different than the multiple myeloma?
Absolutely. So ultimately, our goal is actually for that to be the case, right? I mean, we don't want our patients to die for any reason, but ultimately, we don't want the myeloma to be the thing that causes their problems later on. So yes, we do, kind of. We hope that patients pass away ultimately from other things. The word cure, I think, is it brings so much hope, and I think that we don't want to take that away. It's very hard to have those initial conversations where you're saying to a patient, this is not curable in most cases. We are starting to say, there are probably a subset of patients who have been off treatment, who are doing well and really don't have a recurrence of the disease. It probably is true that in some patients, this is curable. I would say for right now, based on the treatment strategies we have, that is still a minority of patients. And I think that psychologically, I try to prepare patients for the eventuality that they may very well be on treatment for a very long time. And it's not to say that the disease will be active during that time. Actually, it very hopefully will not be active during that time. But because it is still such a small group of patients who can be off therapy and have disease responses that are that deep, I think I still hesitate to use that word as a promise for patients up front, right? And I think that's, it's just a little bit of sort of assessing the psychology, having a one-on-one conversation with the patient and really talking about both possibilities, but that, ultimately most patients need treatment, but the treatment is tolerable and can get them many years of good quality life.
Yeah, and I think that's fair to say. It can be very excellent quality of life with a lot of the multiple myeloma treatments in 2025. And I'm sure, the heterogeneity of outcomes of multiple myeloma very vast, and it's almost impossible to predict who would go on which trajectory from the first time you see that.
That's exactly it. We don't have perfect predictive tools. And if we did, of course, then we would say, hey, you might very well be cured by this. But we aren't there yet in terms of our ability to predict.
Right. Perfect. Okay, so I will close this panel discussion. Thank you so much, Dr. Cooper. Please stay on for the Q&A session at the very end. I will move on to our next speaker, Dr. Julia Zhang. So Dr. Julia Zhang is an assistant member of the Malignant Hematology Department at the renowned Lee Moffitt Cancer Center and Research Institute since 2023. Prior to this, she had completed her Hem-Onc fellowship at the same institution where she excelled as the chief fellow. She has an unwavering passion for cancer immunology and the research for rare cancers. Her innovative work in clinical trial design and translational oncology has earned her multiple accolades, such as the ASCO Young Investigator Award and the Robert A. Wynn Diversity in Clinical Trials Award, including other grants such as the NIH KO5 and the Microbiome Pilot Grant. She's participated in multiple prestigious workshops, such as the ASCO AACR Vail Workshop and the SCION Workshop. She's intrigued by the multifaceted nature of T-cell lymphomas, which is the conversation that she will be presenting today. Dr. Zhang has outlined precise and ambitious objectives for her career, and her primary goal is to be recognized as a clinical investigator in the realm of T-cell lymphomas and therapeutic developments. Rather than solely relying on traditional treatment avenues, she emphasizes the integration of immune system modulation with targeted therapies. Such a pioneering approach sets the stage for groundbreaking therapeutic advances in T-cell lymphoma. So without further ado, I will let Dr. Zhang take it away and present her slides. Thank you.
Thank you so much, Andrew, for this kind introduction. And well, my name's Dr. Yuman Julia Zhang. I'm from Moffitt Cancer Center. I'm a lymphoma doctor, and I specialize in treating T-cell lymphoma. I was a little nervous about this talk because I usually talk to physicians. So I really thank Andrew and the Grace community to give me this chance to directly talk to patients. So without further ado, I'll start. First of all, I think one of the questions I always get from my patients is that why do I treat T-cell lymphoma? And I've been thinking about it and reflecting it for a while. I think those are very challenging, rare cancers, and a lot of oncologists will agree with me. It's very hard to treat. But it is very deeply meaningful to treat those patients and see them getting better. And one thing that I always tell my patients that, they are teaching me more as I teach the science, right? The more I learn from their disease, how I treat them, I can treat the future patient better and help the T-cell lymphoma treatment paradigm to get better. So today, my goal is to help you understand first, what does T-cell do? Second, what is T-cell lymphoma? Third, how do we diagnose and treat them? And then lastly is what question you can ask your doctor about the treatment of T-cell lymphoma. Okay, so we heard on the previous talk, there's a lot of excitement. I'm sure you read it on the news on how T-cell help treating other cancers like multiple myeloma we talk about, B-cell lymphoma, and I think there's T-cell engagers for small cell lung cancer and melanoma. So what are T-cells? So the way I describe T-cells is that they're the soldiers of your immune system. They hunt viruses, they hunt abnormal cells, they help heal your body. They also help fight off the cancer cells. They different than other type of immune cells. They actually act like what I would call them a field commander. They're the brain of the immune system. They direct those cells to go where they need it to be. They live in the blood. They live in the lymph nodes mostly, and they live in the organs like spleen. And they're always on patrol to help you fight off infection, eliminate the cancers and stuff like that. They also can, all our body, all over the organ has T cells, and that's why sometimes T-cell lymphoma can be a little bit hard to control. But when everything works perfectly, T cells just protect you, in the background every single day. So what happens in T-cell lymphoma, or those same soldiers goes off mission? In T-cell lymphoma, those protective cells started to multiply without control, and they stop following the turned off signal to tell them to stop proliferating or stop multiplying. So it kind of feels like it's like an army. They keep recruiting, even though there's no general in charge, and every single soldier just kind of go haywire. They just do whatever they want. So what happened when that happens, they crowd out the normal cells. So they will feel, so you will feel the swollen lymph nodes. Some people will have rashes. Some people will feel very tired because all the nutritions went to the T-cell lymphoma proliferation. Sometimes people can have weight loss. They will have fevers. They will have night sweats. T-cell lymphoma is extremely rare. It's about 1 in 10 non-Hodgkin lymphoma in the Western world. And it's very uncommon. But even though with it being uncommon, it's very heterogeneous, meaning that there's so many subtype of T-cell. This slide is not meant to scare you. I usually use it to quiz my fellows, but you don't have to remember it. This is just to show you that there are more than 30 subtype of T-cell lymphoma. So, and each subtype behave differently, and the exact diagnosis really matters in terms of the treatment. So it's very important for us to make the right diagnosis. And this is a slide where you can see the composition of peripheral T-cell lymphoma, and you can see that their survival, their outcome really are different based on what T-cell lymphoma that we deal with. So this is part of the reason that, when patients come to see me, they're like, oh, I'm seeing you. I was like, no, you're not seeing me. You are actually seeing a group of very expert doctors that not only we do our treatment determination, we have a group of expert hematopathologists that review the slides. And we also have, a huge supportive care radiation oncologist. So you're seeing a group of doctors instead of just seeing the oncologist. And I highly recommend, if it's possible, if you're diagnosed with T-cell lymphoma, always request the slides to be reviewed, at least at a major academic center, to make sure you get the exact right diagnosis, one of those diagnoses in the beginning. And don't be frustrated when you hear maybe a different diagnosis from different doctor. As we learn more, the diagnosis might change. I can give you an example of a lady that I treated. Because of T-cell lymphoma, they're very smart in the sense that they can change expression, they can change the way they organize themselves. So sometimes very hard for hematopathologists even to determine what subtype of peripheral T-cell lymphoma. So I have a lady that came to see me. I really thought she has a very aggressive subtype called extranodal NK T-cell lymphoma. And our pathologist couldn't determine between peripheral T-cell lymphoma versus the extranodal NK T-cell lymphoma. And then what ended up happening is that we finally get the genomic study for the T-cell lymphoma, and then we're finally making a final diagnosis that makes us feel pretty confident about the diagnosis. So again, the correct diagnosis equals to the best treatment, and the best treatment, and also opens the access to clinical trials. And it's important. We have a lot of clinical trial going on, and they're the ones that are testing the newest therapy. Okay, so how do we diagnose T-cell lymphoma? And well, today's talk will focus on peripheral T-cell lymphoma. There is a different subgroup of T-cell lymphoma called cutaneous. They're much more different than peripheral, but we'll talk about peripheral T-cell lymphoma first. So peripheral T-cell lymphoma, as I said, the most important part is the histological, the diagnosis of subtype of T-cell lymphoma you have. So usually physicians, we start with a core needle biopsy. So it's a needle, but with a little bit bigger needle to get some parts of the lymph node out. But often enough, we actually need to do a surgery, a small surgery, to get one of the lymph node completely out in order to make the diagnosis. To me, this is the most important step, to know what subtype of T-cell lymphoma you have. And that allows our expert hematopathologist to look at the cells, to look at their shapes, and add those special genomic markers or immunostem markers, protein markers that we needed to further the diagnosis. The second part, after we make the right diagnosis, we kind of trying to see what's the extent of the lymphoma. So we do bone marrow biopsy sometimes, and then we always do a PET scan, not a CT scan, to see the extent of the disease. And then sometimes we always perform, we try to perform the molecular test to look at what mutations are there. And lastly, once we get all those information, then we will stage the patient. And this is kind of important to understand. A lot of my peripheral T-cell lymphoma comes in advanced stage, like stage 3 or stage 4. And this is very different connotation when you look at solid tumor, right? In solid tumor, when we hear stage 4, it's incurable. Well, might not true in nowadays, but back before then, it was always stage 4 incurable. Then I have to live the disease for the rest of my life. In the lymphoma world, stage 4 means you're going to have a little bit more aggressive disease, but the goal, at least the initial goal, is always trying to cure those patients. And we do have long-term survival, even if we see a stage 4 disease. And that has something to do with your immune cells tend to just travel all over the place, because that's the nature of their function for their body. So Here is the staging. So you can see if it's just one area, then it's stage 1. If it's like both area above the diaphragm or below the diaphragm, then stage 2. If it's above and below the diaphragm, stage 3. If it involves organs like liver or bone marrow, we call it stage 4. But again, don't get too much concerned, and don't all start thinking about stage 4, I'm going to die. Don't. That's not the case for T-cell lymphoma. Okay, so how do we treat T-cell lymphoma? Well, to me, treatment have 3 goals. First goals is get the disease under control. People don't feel well when they have T-cell lymphoma, so the first couple rounds of therapy is always to make them feel better. And then the second goal is really to aim for a long-term remission. The common therapy for peripheral T-cell lymphoma, the first line is usually combination chemotherapy. So you probably hear CHOP, which is a little bit more extensive. In certain patients, we use dose-adjusted EPOCH, or sometimes we add a drug called brentuximab into it if patient is CD30 positive or they have anaplastic large cell lymphoma, which is a subtype. Remember, the subtype tell us what treatment we get. And sometimes we even use additional target therapy for those patients. And based on the subtype, we're going to determine, based on the subtype and the response after you complete the first course of the treatment, we will determine whether or not transplant is needed. And then if we're going to go to the transplant, what type of transplant we do. And then I just listed some common neurotargeted agent that really has pushed the field forward and make my patients survive longer. So that includes your brentuximab, which is a CD30 targeting drug, and then a lot of epigenetic modifier like belinostat, romidapsin, and then duvelisib and azacitidine. And pralatrexate. So those are the newer drugs that we use for relapse disease. And again, if you have ability to be part of the clinical trial, I will highly recommend it. It's important for new therapy, and it's important because the prognosis or outcome of the peripheral T-cell lymphoma is still not good. So trial might be the only option when we move that bar a little bit higher. So this is a better visual presentation of how we treat those patients. And this I borrowed from NCCN guideline. They have a very nice patient education material. So first-line therapy, I usually restage after 2 to 3 cycles. And then if they have good response, I continue to finish. If they don't have a good response, then we start second-line therapy. And then after this, first-line therapy, finish first-line therapy, and they have a complete response. That's where you talk about, the transplant and what type of transplant. And then for second-line therapy, usually for relapse refractory peripheral T-cell lymphoma, we are not able to cure in the second-line setting. So a lot of times, a patient, in order to get cure, right? Cure means not something like, in the great talk earlier about if multiple myeloma can be cured. The cure here means that you're free of disease without needing any treatment. A lot of patients can still, even though they're not cured, they can still achieve this functional remission stage, functional cure stage, where they're on a very reasonable, tolerable therapy. But they have to be on the therapy continuously in order to stop disease from coming back. And then I tend to use a lot of more newer agents, those novel agents that we talk about, instead of chemotherapy on the second-line setting. I think chemotherapy is a great choice if you can go to the transplant right away. But if you cannot go to the transplant, chemotherapy kind of control the disease only very briefly, and then the disease eventually relapse. Okay, and how do we manage the side effect, and how do we stay well? So common side effect from the initial therapy is usually people will have fatigue, low blood count, increased infection risk. They will have nausea, and sometimes people might have numbness and tingling in the hands. And supportive care really help manage those symptoms. And the couple of things that I always want to make sure my patient and I make sure my colleague all do is that ask them about, should you get the growth factor for the white blood cell boost? Ask them about if there's better ways to control the nausea, and ask about if you should be on any antibiotics or antiviral therapy to prevent infection. And one question I always get asked about my patient, which they always ask if there's anything they can do to help to get a better outcome. I always tell them that, we unfortunately in the oncology world, we don't have enough study to look at, nutrition, exercise, and mental support, how that helps outcome of lymphoma. But in my opinion, if we can help the immune system to recover and regenerate, then we'll help the body to better fight off the lymphoma. So I tell them nutrition is the most important thing. If they can keep on the same weight through the treatment, they usually can do a little bit better. And I always ask them, they don't have to do heavy lifting or anything, but just walking around, 30 minutes every day, even on the days that they're really tired, can help your body to receive the signal, hey, I'm trying to heal here. And then the last thing is the mental health support really matter too. It's inevitable that patients, once they diagnosed with disease, they're anxious, they're depressed, and as a result, they are not sleeping well. And I think there's always a body-mind connection. So you have to have a positive mind in order for the body to do positively. So if you need any support to help the sleep or help you feel a little bit better, less depressed, let your oncologist know, let your primary care know, maybe they can help you with that. And I really like this quote from this NCCN patient guideline is that you may not control every side effect, but you can control how you face them with knowledge, preparation, and support. Okay, and what happened after treatment? So after treatments, after patient achieve remission or after they're done with transplant, the regular follow-up is very important with oncologists. In lymphoma, we usually say, in B-cell lymphoma, we usually say follow-up for 5 years after you complete the treatment. For T-cell lymphoma, I like to keep my patients forever with me just because there are late relapses that can happen. And the second thing is I always tell patients to be very aware of how they're feeling, to be in tune with their body. If they find area that is new, like it's swollen, or they start developing nice sweat, not the like gentle sweat, but like if they're waking up, the whole bed is soaked, or they start having fevers for a long time, then they really need to contact me and let me know. And I can restage and make sure that if the disease relapse, we catch it early. And, long-term survival exists, survivors exist, even for very aggressive subtype, as well as for patients with stage 4 disease. So don't lose hope. We're improving the outcome through research and collaboration. And I think that's something that makes me very excited about the future of T-cell lymphoma treatment. And this is one of the cancer survivor told me, and I think it's very highly philosophical, and I really liked it. So I put it here. So every follow-up visit isn't just a check; it's a step forward in your story of healing. So the last slides, I kind of want to put it out there. What are the questions that you should ask your doctor wherever you are in the nation? Is that the first question is that ask your doctor what exact subtype of T-cell lymphoma do you have, right? T-cell lymphoma itself, it's not it's not an adequate diagnosis. You have to know what exact subtype, right? If they tell you peripheral T-cell lymphoma, ask exact subtype. What exact subtype of peripheral T-cell lymphoma do I have? The second is that, what is the goal of treatment? Are we trying to treat for cure, or are we trying to treat to stop the disease from progressing further, but I have to be on the therapy for a long time, I cannot be cured? Because that really determines how much side effect, right? Or like this risk benefit. If you have a therapy that keep the disease under control, but you live miserably, then it might not be a good therapy for you. And there's a lot of therapy we can try in T-cell lymphoma. So, so always important to understand why, how, what's the end goal of the treatment. And for our female patients, women patients, I always, ask about if you're planning to have a baby, there's ways that they can preserve eggs. There's ways that to protect your ovary during the treatment, but that has to be done earlier and pretty well thought of before the treatment. And then always ask about the side effect, and also ask them about, stem cell transplant, or if you can be considered for a clinical trial. And here are some information and resources for T-cell lymphoma. So the NCCN patient guideline, where I steal a lot of photos from, is very helpful. And you're already here, so the Grace community have a lot of good resources. Lymphoma Research Foundation and Leukemia and Lymphoma Society has very nice videos about T-cell lymphoma as well. And then there's a T-cell Leukemia Lymphoma Foundation. And for patients with cutaneous T-cell lymphoma, I will highly recommend to be connected with Cutaneous Lymphoma Foundation. They have this weekly webinar between patients, and they have someone to navigate about the symptoms, treatments, trials, and everything. And then, of course, in your specific cancer center, they might have patient and family services. So I list one of the example for Moffitt. So I like to close it with a quote I saw at our Moffitt Cancer Center, and that's why I said our patient really teach us a lot, not just about science, but also about life, right? So information give you power, connection give you strength, and together they give you hope. So I hope you enjoy this talk, and then we can talk more in the upcoming sessions. Yeah.
Yes, thank you so much, Dr. Zhang. Loved your talk. Very patient-friendly, patient-forward. Just one clarification on that last slide. I also love Leukemia and Lymphoma Society, but I do think they changed their name. I think it's now Blood Cancer United, right? Because they're trying to be like more inclusive to all the different types of blood cancers. So
Okay.
like
Oh, that's
a month or 2 months. So very, very recent.
okay. I like the new name. I think it makes more sense.
It's a great name. It's a great name. So stay on. The panel discussion will happen very shortly. We will move on to our next topic from Dr. Amar Kelkar. Dr. Kelkar is a stem cell transplantation physician at the Dana-Farber Cancer Institute and is an instructor in medicine at Harvard Medical School. He sees patients for allogeneic transplantation and cell and gene therapy, treating many blood disorders, including leukemia and sickle cell disease. He also directs the Bone Marrow Transplantation Survivorship Clinic and co-leads the gene therapy program. He's a member of the ABEL laboratory with research interests in hematology, care delivery, health economics, medical ethics, public health, and health policy. He completed his master's in public health and clinical effectiveness at the Harvard T.H. Chan School of Public Health in 2023 and received the ASTCT New Investigator Award in 2024. His work has been published in journals including the New England Journal of Medicine, Annals of Internal Medicine, JAMA, and the Journal of Clinical Oncology, as well as in Stat Opinion. He also has research in interest in health policy, medical advocacy, and serves on the American Society of Hematology Committee on Practice and Subcommittee on Reimbursement, the American Society of Transplantation and Cellular Therapy Value and Health Economics Special Interest Group, and the Massachusetts Medical Society Committee on Publications that oversees the New England Journal of Medicine group. He previously served on the MMS Board of Trustees, the AMA Council of Legislation, and the AMA Resident Fellow, Section Governing Council Delegate to the House of Delegates. Gosh, many accomplishments. So we will just move on to his presentation, which is for emerging cell therapies. And we're very, very much looking forward to your presentation. Go ahead and take it away, Dr. Kelkar.
All right. Thanks so much for having me. Again, just very briefly, my name is Amar Kelkar, and I'm a stem cell transplant and gene therapy physician at Dana-Farber Cancer Institute in Boston, Massachusetts. And so we'll be discussing emerging cell therapies. First off, I have no relevant financial disclosures or other conflicts of interest. And now jumping in, I want to talk a little bit about the broader concept of transplanting cells, and then we'll go into specific cell therapies. Now, historically, when we talk about uh, bone marrow or stem cell transplant, we're collecting stem cells or the basic building blocks from our bone marrow that make all of our blood and immune cells, as well as platelets, and later infusing these cells into a patient. Autologous or auto transplantation is infusing a patient with their own cells that were previously collected. And in this type of transplant, we collect the patient's own stem cells before giving them very strong chemotherapy to kill as many cancer cells as possible. Because the treatment often or also harms the bone marrow, we then give previously collected and stored stem cells back afterwards to help the body and marrow recover. This works very well for certain cancers, especially types of lymphoma and multiple myeloma. Allogeneic or allotransplant is infusing a patient with donor stem cells. And here we use stem cells from a healthy donor, usually a sibling, parent, child, or sometimes an unrelated person who's a close match using our white blood cell or HLA type. The donor's immune cells help fight any remaining cancer cells and rebuild your bone marrow. And before this transplant, we give lower doses of chemotherapy or radiation to make room in the bone marrow for the donor cells to take hold. Now, there are newer versions and next steps to these therapies that are being evolved, and both transplants can be further tuned through things like giving additional T cells afterwards, or training these therapies to recognize certain cancer cells. And that latter part is what we think of most of the time when we talk about cell therapies. We can also change or modify the genes in these stem cells um, using tools like viral carriers or CRISPR, and this turns them into a gene therapy. Now, we perform a lot allotransplants or allogeneic transplants for a lot of conditions, some of which we've heard about earlier today, but the vast majority of these are types of acute and chronic leukemias, myelodysplastic and myeloproliferative neoplasms, as well as other conditions like lymphomas, particularly T-cell lymphomas. Now, we used to also perform allogeneic transplants for multiple myeloma, but there was a large clinical trial in the last decade that showed that it didn't provide enough benefit for multiple myeloma, and this is especially borne out given all the new and exciting therapies for multiple myeloma that you heard about earlier today. So we don't typically do allotransplants for multiple myeloma anymore, except in special cases. And then we also perform allotransplants for non-cancerous conditions for diseases like severe aplastic anemia, sickle cell disease, and other inherited white and red blood cell diseases, as well as for some autoimmune diseases, which is where the immune system attacks a patient's own body without them having a cancer. There's also autotransplants, as we mentioned, and we still use these to treat multiple myeloma and multiple types of lymphoma. And there are also ongoing clinical trials looking to use autotransplant for autoimmune diseases, with one recent study showing increased length of life in patients with severe systemic sclerosis. There was also one positive trial for autotransplant in breast cancer back in the 90s, but multiple large clinical trials have since shown that unfortunately there isn't benefit for using autotransplant in breast cancer. And while we're about to launch into talking about some of the newer cutting edge therapies, most of the cell therapies delivered are still these unmodified auto and allo transplants that cure a lot of cancers and save lives. And so that's why I wanted to make sure we at least touched on those so that you guys know that those are still happening. And that's the majority of what I do on a day-to-day basis as a clinician. Now, cell therapies, as we were talking about, in what we commonly think about are when we take those stem cells or T cells or other types of cells and modify them to turn them into targeted medicines. And most current cell therapies are created outside the body or ex vivo. Doctors first collect those immune cells from the blood using a process similar to what's done for stem cell transplants. And these cells can come again from your own body or autologous, or from a donor, which is allogeneic. Scientists can then re-engineer different types of immune cells, most often T cells or natural killer cells, which are NK cells, to better recognize and attack cancer. Some of these are called CAR T cell therapies or TCR therapies, and the names depend on how the cells are reprogrammed. Gene therapies, as I mentioned earlier, fix or add instructions to make healthier or more effective cells at fighting cancer or other diseases. Gene therapy works by adding or changing genetic information inside cells to help them function better or replace something that's missing. One common method uses harmless helper viruses called AAV or adeno-associated viruses to help deliver healthy genes into the body. And this approach is already approved for some rare blood disorders like hemophilia A and B. And what's special about that technique is that it can actually be delivered entirely in a clinic using an IV infusion without removing any cells. And that's called in vivo therapy, meaning that, again, we don't need to use cell collection or transplant techniques. However, right now, at least, most of the cell and gene therapies that are being developed focus on modifying cells outside the body, or again, ex vivo therapy, which comes with its own benefits because it allows us to do a lot more different things without worrying about these changes we're making to the cells affecting other cells in the body, but also come with their own challenges. And some of the techniques that we use are things like lentivirus vectors, as I briefly touched on earlier, that are retroviral tools that insert new genes. And you can think of a lentivirus like a delivery person dropping off instructions for how to get into and modify a cell. And most current cell therapies use this method to modify T cells. CRISPR or the CRISPR-Cas9 system is used for precision gene editing. And you can think of this like a cut and paste in your word processor on your computer to remove a typo or add a missing word. This is a higher precision method, but its uses are still being explored because, again, of risk of making cuts in areas of the DNA that we don't want to. And so this is still being worked on, but there have already been advances in this area to where there are approved gene therapies for some inherited disorders using this method. There's also two other techniques, one called short hairpin RNA, which is used to turn off certain genes. And you can think of this like a volume button on a remote that can turn off or on genes or sections of genes. And zinc finger technologies that are used to target or repair specific DNA spots. And you can think of this like a lock and key where the zinc finger protein is targeted to a specific part of the gene of interest to change how much of that gene is used. Now, all these treatments begin with a process called apheresis. And that's specifically for the ex vivo treatments, I should clarify. And that's a special type of blood donation. It relies on a similar machine to what's often used to collect platelets during blood donations. And during apheresis, blood is drawn from one arm using an IV, passed through a machine that gently separates out the specific cells we need and returns the rest of the blood back to your body through that same IV circuit. Depending on the type of anti-cancer therapy, we often collect different types of cells. So this is one way we collect stem cells or CD34 positive cells, and these are the seed cells that regrow bone marrow, and they're used for auto and allo transplant as well as gene therapies. We can also use these machines to collect T cells, which are recognized by CD3, and these are the soldiers of the immune system that are trained to recognize and attack infections, cancer, or other unwanted cells. And these cells are collected for CAR T and TCR therapies. And then we can also use the same apheresis machine to collect natural killer or NK cells using the CD56 marker. And these are your first responder cells that can destroy abnormal or disease cells very quickly. And they're collected for some types of the upcoming NK cell therapies. The same basic collection method works whether the cells come from the patient for cell therapy or from a donor for donor-based therapy. Now, what is the timeline for transplant? Now, this often starts with patient identification, but for the purpose of treatment, it starts with apheresis, which is what we just described, collecting the immune cells with the machine. The next step is manufacturing, where the collected cells are sent to a special lab where they're re-engineered to recognize and attack cancer cells. This process can take a few weeks or sometimes even longer, depending on the complexity of the therapy, due to many quality checking steps afterwards to make sure the cells are safe to give back to the patient. The cells are tested carefully before they come back to the patient for infusion, using a bunch of different required methods from the FDA. Next step is conditioning chemotherapy. And so before the cells are given, modified cells are given back to patients, they often are given a short course, usually just a few days, of chemotherapy. For CAR T cell therapies, this is called lymphodepleting chemotherapy because the goal is to reduce the amount of lymphocytes in the body to make room or space in the immune system for the newly trained cells to come in and start working at fighting cancer. The next step is the cell therapy infusion, and this is when cells are ready, they're thawed and infused into the patient through an IV, just like a blood transfusion. The infusion usually takes less than an hour, and the cells immediately start searching for their targets in the body. We often joke that it's quite anticlimactic compared to all the lead up. Patients go through all this setup, and then when they get their cells infused, the first few hours afterwards, nothing happens, and they often feel quite like they just got some blood or IV fluids infused. And then the last step, which is often the longest, is the monitoring and recovery phase. So after the cells are infused, patients are closely monitored either in the hospital or in an outpatient cell therapy clinic for several days or sometimes even longer, depending on the therapy and the patient's symptoms. Within hours to days, these newly infused cells will get to work fighting cancer cells in the body. And one of the challenges is that these seek and destroy anti-cancer cells can cause strong immune reactions that can look like fever, low blood pressure, shortness of breath, or confusion from the outside. So these reactions are common, but usually temporary and treatable. In some cases, however, patients can get very sick and need days to weeks in the hospital or even the ICU to recover. And that's why we watch patients so closely while getting these therapies. After this initial period, patients start regular follow-up visits with their oncologist to ensure their immune system is recovering appropriately and monitor for infectious and immune side effects, as well as seeing if the cancer is responding to treatment. Now, CAR T-cell therapy is currently the most common approved current cell therapy type. But as I mentioned, the other cell therapy types that we'll talk a little bit about are T-cell receptor therapies, which use a different methodology, and NK cell or natural killer cell treatments. So with CAR T-cell therapy, we take a patient's T-cells, engineer them in a lab to carry a chimeric antigen receptor, or CAR, and this gives them a new radar that helps them recognize a specific marker or flag on the surface of cancer cells. And once it's infused back into the patients, they will find and kill those cancer cells. Several of these therapies are commercially available for blood cancers, primarily leukemias, certain lymphomas, and multiple myeloma. And because it's available now, some patients may be eligible based on their cancer type, but it still carries risks and needs to be monitored at a specialized cancer center. T-cell receptor therapies, or TCR therapies, unlike CAR T therapies, are engineered so they can see flags that come from inside the cancer cells. And these flags are broken down proteins from inside those cells that are presented on the surface of the cell that are recognized by these engineered T-cell receptors. This allows targeting of a broader set of cancer-specific proteins and less risk for hurting our own healthy cells. This is mostly used in human clinical trials, or mostly being studied in human clinical trials, especially for solid tumors. So we're hoping to see some approvals in the next few years. But because this particular therapy often requires some higher level of matching for the patients, eligibility for these treatments is a little bit more complex. But it holds a lot of promise, and especially for cancers that don't respond to surface marker targeting therapies, this could be very useful. Probably the one of these treatments that I think is the most promising in terms of next treatments coming out are the NK cell or natural killer cell killer cell therapies. Natural killer cells are immune cells that don't need the same level of training as T cells to recognize harmful cancer cells, and as a result, we can more easily get these cells from a donor, so they can be made in advance without taking cells from a patient. And these NK cell therapies can be harnessed to recognize cancer cell flags from both outside and inside cells, and then kill those cancer cells. Many NK cell therapies are in active human clinical trials as well. And because these can be made off the shelf, meaning they can be made in advance using a donor's cells, and potentially have less side effects than T-cell based cell therapies, they may become more accessible to patients sooner in the near future. Now, CAR T cells that fight multiple myeloma, B-cell lymphomas, and B-cell lymphoblastic leukemias have been available for a few years. And you may notice that some of these cancers treated with CAR T-cell therapies are the same ones historically treated with auto transplant, and that's not a coincidence. when CAR T was first tested in humans, it was used for patients whose blood cancer primarily didn't respond to auto transplants, meaning that they may be resistant to chemotherapy. But over time, this technology has improved, and especially for multiple myeloma and large B-cell lymphoma, CAR T has started being studied and used earlier in the course of treating these diseases. In some cases, it can lead to longer remissions or even higher cure rates than transplant. And what's also exciting about these CAR T cell treatments is that since the ones designed to target B cell lymphomas um, have overlap with certain autoimmune diseases, because both involve B cells that can sometimes become overactive and attack the body's own organs and tissues. So this means the same science that's helped to fight cancer might one day be used to help people with conditions like lupus or multiple sclerosis or things like that. So it's a very exciting area right now. Now, the other group of cells that I was mentioning, the NK cells, as I mentioned, are a type of first responder cells in our body. And unlike T cells, they don't often require a perfect genetic match when we infuse them into patients. They can also act when cancers hide those flags that the T cell targeted therapies look for on the cell surface. And so that's one reason why NK cells are believed to potentially have the ability to excel where other cell therapies might struggle. Now, one modified version of NK cells is called SIMIL-NK, or cytokine-induced memory-like NK cells. And these are made when NK cells get a short boot camp with 3 cytokines, IL-12, 15, and 18. And this training helps them respond faster and stronger and produce more helpful immune messengers like gamma interferon that help them fight cancer cells. And so these SIMIL-NK cells have already started to show promising early activity, particularly against some types of leukemia, which are one of the groups of cancers that we have the fewest treatments for, as you may have heard earlier, as well as some solid tumors. And these are all in active clinical trials. And I have a few patients that have gotten these on clinical trials in the last few months. And it's very excited to see how they continue to do going forward. Now, other next generation NK cell approaches include adding CAR, those chimeric antigen receptor signals on the or radars on top of NK cells, so get kind of helping to further target these treatments. And these are still in very early studies. And then there's also induced pluripotent stem cell NK cells, which are those off-the-shelf NK cells I mentioned earlier, because this basically takes stem cells from donors and then induces them to develop into NK cells. And then further, we go through a process of targeting those NK cells at the cancer cells of interest. And then there are also treatments that combine these cell therapies, like NK cell therapies, with antibodies to supercharge their effectiveness. And this is, one trial I'd recently seen was in CD30 positive lymphomas that may be responding to this type of combination of therapies. Now, again, the most important thing I think for patients with these NK cell therapies, in terms of why they're exciting, is that there's shorter manufacturing times. There's lower rates of severe cytokine release side effects and neurologic side effects. And so I think that this is an area I would keep an eye out for as we develop new treatments to treat both solid and blood cancers. Now, there are side effects to these treatments, and I recognize in time I will I'll mention that they group into 2 types: the infectious side effects like bacterial, viral, and fungal infections, as well as non-infectious complications like cytokine release syndrome, which is where the immune system becomes over stimulated from these new cell therapies and causes things like fevers, fatigue, shortness of breath, or low blood pressures, and needs some immune suppression in some sense to cool off the immune system through steroids or through other targeted treatments. And so this requires very close monitoring in those first few days after the cell therapies. There's also neurotoxicity that can cause confusion or trouble speaking or writing or headaches. And again, this is usually reversible, but requires steroids and often very, very close monitoring in the ICU. And then there's other side effects like low blood counts and bleeding and nausea and vomiting and diarrhea, and common things that you think about in cancer treatments. And these are all treatable and reversed relatively quickly after the treatments are done. So in terms of what's next in cell therapies, as I mentioned, we have CAR T cell therapies and TCR therapies and NK cell therapies that are all coming down the pike. We have newer types of CARs that are being developed that have off switches or kill switches to slow them down in case they become overly or hyperactive. So thinking of that like an emergency brake for these treatments. We have off-the-shelf therapies, like I mentioned, for NK cell, as well as some developing off-the-shelf T cell therapies that require a little bit more matching. We have in vivo editing that's still being developed and more for gene therapies, but hopefully eventually for cancer-fighting cell therapies as well. And then we have smarter ways of tracking which patients might need treatment earlier using things like liquid biopsies or ctDNA testing. And then there's also a lot of promise for some of these T cell and NK cell therapies for targeting solid tumors, which is really an area of need. And so I think there's a lot of exciting things coming for cell therapies, and I hopefully many of you guys get the opportunity to experience them if you need them, and get to learn more about them. So I just want to thank everyone for their attention. Sorry, I went a few minutes over, and we can discuss any questions during the Q&A session.
Great. No, that's okay, Dr. Calcott. Thank you so much for that. It's amazing where we are with cell therapies and gene therapies. And, if 10-year-old me were to be able to see what's available in 2025, I really would have thought it was science fiction. So we've come a long way, and it's very exciting. So we'll talk about the panel discussion right now with Dr. Zhang and Dr. Kalkar about lymphoma and cell therapies, respectively. I will end it on time at 12:55 so that we can go straight to the Q&A session. So I think I only have time for maybe one or two questions. Dr. Kalkar, one of my questions for you is about costs and accessibility of cell therapies and gene therapies. Could you comment on that? And then maybe broadly to both of you, where can patients get these products? Do you think that they're available in the community or will ever be available in the community? What do you think about that?
It's a great question. And as you had mentioned earlier, one of my areas of interest is kind of addressing the high costs related to these treatments. Basically, every single one of these cell therapies starts at a list price of somewhere around $400,000, and that doesn't even include the cost of the hospitalization and transplant that goes with it. So they're exceedingly expensive, and we don't right now, at least, there isn't a consistent model to figure out how to pay for all these in a way that makes these treatments accessible to every patient. And so that's one of those areas where we're looking at different things, whether it's kind of value-based reimbursements or some other ways of making sure that patients and health systems are not paying for treatments that are not effective, and focusing those kind of payments back to companies and for treatments that are working the best and adding the most length of life and quality of life for patients. So it is to say it's an evolving area. It's a big concern for, I think, all of us, but it is also, in some sense, a good problem to have in that we have these exciting treatments to begin with, that we can have these conversations.
Yeah, and I completely agree with that. So is it isolated to academics? Maybe Dr. Zhang, do you feel that in any way?
I do think like with diffuse large B-cell lymphoma or aggressive lymphoma, that's the only chance for a cure in the relapse refractory setting. So even though, we talk about cost, we talk about access, we also have to talk about patients, right? They have to have a caregiver, they have to be able to travel to a place that they're not familiar with, and that sometimes deter them from getting the therapy. One thing I do think that we can probably do a little bit better to in the future is to select people that are highly likely to respond. If we can do that, then that might make the treatment more feasible. I don't know if community centers, I think big community center definitely can do CAR T, but like smaller standalone cancer center or cancer clinic probably will have a difficult time. So yeah.
Got it.
Yeah,
Probably a support that is required around the products, right?
Yeah, it's extremely resource intensive. And that, as I mentioned a little bit about side effects, like there's just a lot of monitoring involved and close follow-up. And so I think you really do need experience and expertise. And, places like Moffitt, where you guys do a lot of these, obviously, I think that's a big center, but it is harder to deliver these at freestanding cancer centers.
Yeah. In my clinic, I treat a lot of MPN patients, and I have some untreated ET patients. They're not even on therapy, but they ask me, hey, how about cell therapy for this disease? And, I know it's not indicated, but it made me think, do you ever feel, especially with new CAR NK products, do you ever feel that the lines will come up even more to the point where we'll have some safe product in the first line setting? Because you showed that the right now it's all relapse refractory, second, third line, or even later. But do you think it's feasible that this could eventually be first line, or we're still probably a little too far with the toxicities?
I think probably even more than toxicities, it is difficult to make it first line therapy that can't be offered everywhere. You want you want a treatment that everyone can get in the first line, because you want something that will, yeah, accessibility is I think probably the biggest limitation, but also clinical trials just haven't gotten there. So we obviously in myeloma we just saw 2 clinical trials that looked to move CAR T up to second and third line, and those were approved in the last year. And lymphoma that happened about 3 or 4 years earlier. So I think it is coming. There are some trials in lymphoma that are already looking at first line, but those haven't been read out. And Dr. Zhang probably is more familiar with those even than I am.
Yeah, we do have a couple clinical trial that kind of consolidates the initial therapy, like high risk and stuff like that. So we try to do it for our high risk patients. But to answer your question, I don't think it's going to replace R-CHOP for undifferentiated patient. Like think about it, you have to wait for the cell to manufacture to get the treatment. So you're delay on that sense. And like upfront chemotherapy has a pretty good efficacy in B-cell lymphoma. It's very accessible. But I think for those high risk patients and people with MRD, like towards the end, if they have access to clinical trial with CAR T, I will highly recommend it. It will help the science, as I said, as well as them, because the relapse rates are higher. So if we can select those patients, it will be pretty amazing to see how they do. Yeah.
And yeah, just to double click on that, I think that those high risk patients are the ones that we're seeing in myeloma also, being studied for smoldering myeloma trials and things like that, to try and catch people before the disease gets really severe, in the hopes of maybe going from what was mentioned earlier as kind of long-term remissions to cures. So I think there is potential, but yeah, it would only be for a very small subset of people with these diseases, I think, anywhere in the near future.
Well, it goes to show you how siloed I was, because I wasn't aware of these consolidation trials in lymphoma. So it's very exciting that we're seeing these cell therapies even earlier. And you bring up a good point, Dr. Kelkar, that one thing that I know patients talk about a lot is, if I have a precursor like CHIP and MGUS, like we talked about an hour and a half ago, like what do we do about it? And this could be a potential solution in clinical trials, is that maybe we can slow down the progression of the precursor lesion like MGUS with some type of bispecific T cell or something. So more to come. I think that the cell therapies are going to be in all phases of disease, mostly in the relapse refractory, but very much could be in the precursor lesions. So I'm going to end the panel discussion right now so that we can move on to the Q&A session. We already have quite a few, actually. So if Dr. Cooperrider could join us again, as there are multiple myeloma questions. I want to preface though. So I will be speaking about these questions on behalf of the audience. I do think it's worth noting that us as treating physicians, we hope to offer you our general advice about these questions, but I do want to emphasize that treatment decisions are very complicated and are very contextual. So while we would happily recommend our general advice, what's actually happening to you might be much more specific to your condition and context, and the real best treatment decision is from your treating provider. So please take our answers as general answers, as opposed to your specific clinical context. So with that said, first question is probably for Dr. Kelkar. Can you tell us a little bit about the neurotoxicity of CAR T cells and how often it seems to occur?
That is a great question. So, the neurotoxicity, as I briefly touched on, is something that usually happens somewhere in the 3 or 4 to 10 day range after a transplant, after the cell therapy, and can for a patient with severe symptoms, the symptoms can actually carry on for quite a while longer than that. But those neurotoxicities can start with things like mixing up your words or getting confused. Sometimes they can look like headaches or changes to your sensations or vision or things like that as well. And so they're caught usually because we're screening patients along the way. We're giving them a series of usually about 10 questions that we ask them in a row that are testing their executive thinking, as well as having them write the same sentence every day to see if their handwriting is changing. And so those are all just kind of clues that patients are getting worse in those situations. And then uh, in terms of treatments for that, as I mentioned, we often start with things like steroids. We'll image the brain to see if there's any signs of swelling, because that's usually one of the key clinical signs that patients are getting sicker faster in terms of complications. And then sometimes we'll use other treatments as needed. In rare cases, even surgical interventions are needed. But that's kind of usually what we see with neurotoxicities.
I might add too, when we're using Carvykti, which is a myeloma-directed CAR T, there's delayed neurotoxicity as well, which can look somewhat like Parkinson's, or it can look, there's cranial nerve palsy. Those were more common with the trials where it was done later. And now that we're using it earlier, it seems to be less common. And so we're using some preventative strategies as well as using the cell therapies earlier, which seems to be improving the chances of getting that, decreasing the likelihood.
Perfect. Thank you so much. And I should clarify too, if any of the other speakers, even though I address one particular person sometimes, if any other speakers have more comments about a specific question, like Dr. Kruger had said, please join in. We welcome this conversation. So this next one is quite specific for multiple myeloma scenario. So I'll say the question for Dr. Cooper Ryder, although we might want to make it more of a more broad, how do you approach post VRD, and maybe explain what VRD is. But the question is, do we give a patient with multiple myeloma on pancreas and pelvis any algorithm to cure after VRD cocktail chemotherapy and acupuncture and traditional herbal medicines a year in stringent remission and collected stem cell without bone marrow transplant, VRD light maintenance therapy a year, and Velcade chemotherapy 7 years? Dr. Kuberta, are you actually able to see the text of the Q&A?
Yeah.
Okay.
It sounds to me like this person's describing a situation in which they've had a very good response to what we call triplet therapy. So I talked about it's either usually 3 or 4 drugs that we use in combination in the frontline setting. And so VRD is a combination of 3 medications. So Velcade or bortezomib, which is a proteasome inhibitor, Revlimid or lenalidomide, which is an IMiD, and dexamethasone. And that was sort of before daratumumab was approved. That was the standard of care frontline therapy. And so it sounds like, this patient has had a very good response to therapy, including maintenance therapy and a long course of Velcade chemotherapy as well. So obviously I won't answer necessarily for this exact situation, but as we said, kind of zooming out, is there a way to maybe call a situation a cure? It goes back a little bit to what we were talking about earlier. I think we're using a lot of MRD negativity now, looking for sort of 1 in a million cells to figure out if a person is in the deepest response that we can detect. And so we did a trial called MRD to Stop, which was hypothesis generating, which was a trial where basically we discontinued maintenance therapy in patients who had achieved MRD negativity at 1 in a million cells. And they had done that they had achieved that, after at least a year of maintenance therapy. Dr. Dermott at our center led that trial. And what we found is that 3 years later, 85% of patients who achieved that deep level of response are still in remission, which is nice, right? I think that what we've found, what we're finding more and more in myeloma is that patients that achieve this really deep response may actually, maybe functionally be cured, or at least can be off therapy for some period of time, that maybe they're not getting additional benefit from additional therapy. So, don't know exactly about this situation, but I do think there's a little bit more data that could be added here, which would be MRD negativity. That would be something that would kind of help, at least in my mind, with the data that exists currently, which doesn't necessarily say that people would be cured, but if we couldn't detect it, then there might be a pathway to talking about whether somebody could be off therapy. Knowing whether somebody is definitely cured takes time. We wouldn't know that, until later on down the road, but it does seem like there might be a path to discontinuation of therapy safely with close monitoring, if somebody has a really deep response to treatment.
That's perfect. And actually, I'm really, really happy that you brought up the idea of MRD, or measurable residual disease, as honestly, the next 3 questions have to do with MRD. This is for Dr. Cooperrider and Dr. Zhang. I think one overarching question prior to the specific patient question is, what does MRD mean to you? How do you assess for it? Is it going to be different in your diseases? Because the questions are the following. 1, do multiple myeloma patients have MRD negative for many years? For lymphoma, do you apply MRD negativity to T-cell lymphoma patients during treatment periods? Do you test MRD negative for lymphoma by mass spectrometry? And are there MRD tests for follicular lymphoma? So I think that there's a lot to tease out there about MRD and multiple myeloma and lymphoma. I don't know if you guys have, I'll let Dr. Cooperrider speak first, actually.
Okay, so I talked about how we do MRD testing pretty frequently from the bone marrow, which seems to actually does have some prognostic significance, that may even be better than our older traditional response criteria that we've been using. And so we kind of use it alongside our typical response algorithm to understand how deep the patient's response is. And they talked about sort of, can they be negative for many years? Patients can be negative for many years. And actually the prognosis that has even more prognostic value when patients have sustained MRD negativity. And so that can happen. And then, we use mass spectrometry sort of on a research basis right now. This question I think was specifically about lymphoma, but that we use it in the peripheral blood in myeloma to get a deeper understanding of whether there's protein circulating. And so we use that sometimes alongside our response assessment, though in terms of having enough data to use it for decision making in prime time, we probably don't have enough data to do that totally yet. But sometimes I think, it could be used alongside other modalities as part of a multimodality assessment of depth of response.
Great. Actually, maybe take a step back, if either of you can answer. What is mass spectrometry? And it's really interesting that you mentioned it's in research. Why would one prefer that over the current standards?
So mass spectrometry basically uses ionized molecules. You sort of like use
This is very difficult, isn't it?
yeah, I'm like, are there any scientists on this call? They basically use like the mass to charge ratio to identify specific protein combinations. Maybe somebody else can even answer this better than I can. But basically what it allows for peripheral blood testing of, residual disease that's more sensitive than what we have with our current kind of SPEP and immunoglobulin assessments. And so we can understand from the peripheral blood, so the marrow obviously being the most sensitive for myeloma, but deeper peripheral blood could maybe help us forego some of those marrows if we could get a deep enough assessment in the blood. And so mass spectrometry allows for some of that. And I do think, in combination, it again kind of improves some of the prognostic abilities of our testing.
Okay, perfect. And then circling back to the lymphoma questions, Dr. Zhang, do you apply MRD to T-cell lymphomas? And are there any MRDs for follicular lymphoma?
Okay, so well, for mass spectrometry, it's a protein testing, so we don't really use it in we don't really use it that much in lymphoma. We usually use DNA-based testing. Do I apply MRD testing to T-cell lymphoma? So this is such a great question. So it's hard to answer. I think there is utility of MRD in T-cell lymphoma, especially after patient complete that initial induction chemotherapy to decide on whether we consolidate, what do we consolidate with, what type of stem cell transplant we do. But all of those, but we don't have a perfect MRD test on market right now for T-cell lymphoma. We have a couple ones, but they're we don't know specific cutoff, right? Like every time we talk about MRD testing, we're talking about cutoff. You can have no disease at all, right? Or you can have a little bit disease, or you can have a lot of disease, right? And then when we say someone is MRD negative, we just pick a level of very minimal disease cutoff. But still, there are some patients still might have disease, right? And then that little bit disease doesn't matter. How much does it matter, right? Because ultimately your immune system can potentially take care of very little disease. So in T-cell lymphoma, I don't think we have the test, a perfect test yet, and we don't know the cutoff very well. But on the other hand, I do MRD testing on my T-cell lymphoma patient, especially during chemotherapy, and that's on a study. So the decision where I make the decision is that after treatment for lymphoma, if you guys, sometimes you can have a little bit PAT positive, right? Like it can be in the hilar lymph node, it can be somewhere it's really hard, and then you just keep biopsying, but you just don't see the disease. And then you're wondering if that's the disease, that's inflammation. So I think MRD testing can really help figuring out if that's the inflammation or disease. And for T-cell lymphoma in particular, about peripheral T-cell lymphoma or TFH lymphoma, so very specific subtype, I think you really have to reach to an MRD negative in order to benefit the most from autologous stem cell transplant. I think there's a study out of MGH looking at MRD testing. Almost all the patients with MRD positivity end up relapsing if they don't if they underwent autologous stem cell transplant. So that's a transplant from your own blood. But that's in a research setting, and we don't have a lot of patients. I think that study has like 10 patients or something. So I think it's a very promising field really for T-cell lymphoma. I test it so I can gain some knowledge. I tell my patient, don't look at the numbers, I will interpret it for you. So that's that. And then MRD test for follicular lymphoma. So I do MRD testing for follicular lymphoma, but only in early stage, like extremely early stage 1, and my goal was cure. Remember, the paradigm of follicular lymphoma is that we do not think follicular lymphoma can be cured no matter what you do. From the historical data. But for patients that have very early stage, you can potentially cure with radiation, plus minus a little bit rituximab. So those patients, I do MRD testing. I think the MRD negative give me a little bit more confidence of cure. That hasn't been shown in the literature, but it does give me that more confidence. But MRD testing in general is not covered for follicular lymphoma. We usually use it for diffuse large B-cell lymphoma and mantle cell lymphoma. But I think there's definitely utility. But remember, for non-curable disease, the MRD, like just repeated testing add to the cost, and you're not changing what you do. Follicular lymphoma, you can wait a long time before you start treatment. So that number going up and down, to me, if we keep testing it, just cause more anxiety than anything else. Yeah.
Yeah, that makes a lot of sense. And that's great that you're looking at MRD and research to ask and answer the question of what does this mean and what is it related to? So more to come. There's a lot of myeloma questions in the past couple minutes. So I'm going to switch to a stem cell transplant question for Dr. Kelkar. Dr. Kelkar, how long does a stem cell transplant procedure take and how long is recovery? How long does it take to work? I presume the question is about allogeneic, but maybe if you can comment both on allogeneic and autologous, that might be helpful because I think patients might be experiencing either.
Yeah, so starting with allotransplant, there's a lead-up period of usually what we called conditioning chemotherapy for the usually about 5 to 7 days before, depending on the regimen that you're getting. You'll get your stem cells infused usually on what we call day 0. It's like rocket ship countdown for launch. And then after that, we start counting up in days. You'll usually receive treatments to prevent a complication called graft versus host disease in the coming days after that, usually somewhere in the first 5 to 10 days afterwards. And then after that, usually about 2 to 3 weeks after you get the stem cells, you'll engraft, meaning that the stem cell or your neutrophil counts will start to come up. And that will result in you being able to at least have some initial first-line defenders that will allow you to leave the hospital or leave the transplant daily clinic and go back home and start seeing us on more like a weekly basis. So that's usually, that engraftment or somewhere between days 15 and 20 for most people is what we usually consider to be the end of that initial transplant period. But then for most centers, the first 100 days is a kind of very special period where you're very closely monitored. Mostly for graft versus host disease, but also for infections and relapses and things like that. And then for most centers, and certainly for our center, the 1 year mark is the other big milestone. And that's usually the time period where we still keep people under pretty strict precautions for infections. And also kind of ends the highest risk period for when you could have a relapse. So those are kind of the 3 milestones. And then I usually don't call people cured for a few years afterwards, usually for AML or acute myeloid leukemia, till about 4 years or so afterwards when we start throwing around that word. But that's for allotransplant, that's kind of the timeline we look at. For auto transplant, it's very much use dependent, and obviously we have folks from lymphoma and myeloma here who probably see this even more on an individualized basis. But generally, it's a shorter period to engraftment because it's your own cells, and we're not using immune suppression or anti-rejection medications to prevent complications. So people tend to have their cell counts come up faster. The preceding chemotherapy is often a little bit, or not often, but sometimes a little bit longer in the auto transplant setting for lymphoma, a little bit shorter for myeloma, but it's a much higher dose of chemotherapy because the goal of auto transplants is to give a high dose chemotherapy and then rescue the bone marrow with your own stem cells. Whereas allotransplants, typically the transplant itself is the treatment. And so in that case, we're hoping for those transplanted cells to fight cancer for you. So for the auto transplants, you'll get chemotherapy before, you'll still get your cells on day 0. And then usually somewhere between 10 and 14 days after, for most people, they're going to engraft their stem cells, start having sufficient neutrophils and platelets to leave the hospital or transplant clinic. And then usually they'll follow up with their oncologist sometime in the next few weeks afterwards. And so the follow-up is a lot more center dependent for auto transplants. And the expectation of time of duration of that treatment in terms of response is very much dependent on the type of disease and the risk status of your disease. So for multiple myeloma, I think traditionally, and Dr. Cooper, you can correct me if I'm wrong, but usually we think of it, I was always taught that you expect about a 2-year remission on average, or somewhere in the 1 to 2 year range. And then for lymphoma, we're usually going for cure when we use auto transplants. So it's the 2 different uses there. And then it was, auto transplants used to be used for other things like leukemias as well, although a lot of the recent research has showed that most patients relapse very quickly after auto transplants. And so that's why we almost always use allotransplants for leukemias and MDS.
Yeah, perfect. That actually kind of touches on one of the questions later on. It says, where did I find it? What's the difference between using my own cells and a donor's? What are the advantages and disadvantages? So, this is actually something I wanted to ask you during the panel discussion, but we didn't have time. Is what I struggle with in clinic is why as a patient would I want to do an allogeneic transplant when autos exists? But it's, I think it's a hard concept to understand that, maybe autos are not, like you said, in leukemia. Like, I'll let you answer this question.
Yeah, no, it just depends on the disease. I think allotransplant for, say, something like multiple myeloma, we have good data that shows that there really isn't a lot of benefit in terms of extending time away from active treatments for myeloma or cures, while it comes with a lot of potential side effects. But for diseases like lymphoma, it can be a backstop for frontline treatments that if they're not working, at least you can rely on an allo transplant to potentially be a curative option if nothing else is working. So I use this often more when I talk about non-cancerous disorders, but I think of allotransplant as the high risk, high reward option. The likelihood of a cure with allotransplant for a lot of these diseases is very high, but it comes with a risk of graft versus host disease, of higher risk of infections, and in some sense, a little bit of maybe not lifetime monitoring, but certainly much more long-term monitoring for complications than some of these other treatments. And so that's why I think if we think of ourselves as kind of like the back of the line treatment for a lot of things, except for uh, acute myeloid leukemias and MDS, because of the limited number of treatments that we have for those diseases. And then for auto transplants, it's very much, for the diseases it's curative for, we would prefer using that first.
Right. So it's context dependent. It's not just the treatments are effective across all diseases. It really just depends on each disease.
Yeah.
So the next question is probably for myself and potentially Dr. Kalkar as well too. How do you know what subtype of acute myeloid leukemia you have? This is a great question and honestly extremely challenging to answer. And the reason why I say that is because I think we do a disservice to our patients right now because there are two competing diagnostic criteria for acute myeloid leukemia and myelodysplastic syndrome that do not align. And this is a big problem because there are some criteria that would say a patient has MDS and some that says patient has AML. And we tell patients, you could have either depending on which criteria we are looking at. We're this problem will be solved next year when there's going to be a unifying consensus. So that's number one, is that it's currently very confusing. Number two is that there are many different ways that you can call a subtype. You can call a subtype based off how it looks under a microscope. You can call a subtype based off of a risk for progression of disease or overall survival or chance of relapse to transplant. That's a very useful risk stratification system way to think about subtyping. But I think a more pragmatic way to think about subtyping is how does it affect my treatments? So in my opinion, the most effective way to think about this is, do I have a targetable mutation? So what I mean by that is that in acute myeloid leukemia, there have been a number of genetic mutations that we've identified that quote unquote drive this leukemia to exist. And we can similarly turn off that driver leukemia gene with therapies. So you may have heard of NPM1 or FLT3 or IDH1 or IDH2. These are very important, or KMT2A rearranged. These are very important molecular targeted genetic abnormalities that a patient may have in acute myeloid leukemia that have therapy decisions associated with each one of those. Or you may not have any, and therefore you are kind of the de novo agnostic leukemia, and therefore get kind of the traditional chemotherapies. In my opinion, that's the most useful way to think about it. All the other systems are very complicated and probably are better reserved for physicians to kind of interpret. Dr. Kelkar, do you agree with that? Would
Yeah,
be a better
very.
way to think about it?
No, I similarly use a similar system, and obviously being a transplanter, I think for us it very much is this disease subtype that's going to benefit from more frontline treatments and kind of delaying transplant, like say a lower risk NPM1 leukemia that doesn't have secondary mutations and might and is MRD negative and might benefit from being monitored and not getting a transplant versus some higher risk types. So again, I guess the molecular ontogeny, I think, has well, for better lack of a better term, the types of mutations that your leukemia has are I think right now the most useful things as a patient to help determine what treatments you're getting. So I very much agree with the way you're thinking about it in terms of how patients should look at it.
Perfect. Thank you so much. Dr. Cooper, we have 3 myeloma questions for you. Very heavy myeloma audience today. So first question is, I have myeloma and severe neuropathy. What's the best treatment? So I think that might be helpful to kind of talk about how to treat or how to support the neuropathy. Number 2, are some people more likely to develop myeloma than others? And number 3, can myeloma spread to other areas of the body?
Yeah, so starting with the neuropathy question. So neuropathy is a common side effect of Velcade or bortezomib, which is one of the frontline agents that we're using in myeloma most frequently. So I think when I'm thinking about neuropathy, people that are, we have to, think about patients that are high risk for neuropathy going into treatment. So those patients are patients with other conditions that can cause neuropathy, like diabetes. But also there's a syndrome that overlaps with myeloma, which we didn't talk about today, called amyloidosis. And patients that have amyloidosis, which is where proteins kind of misfold and deposit into tissues, those patients can also be at high risk for neuropathy. So we have to consider those things going into treatment already. And then when patients get treatment, neuropathy is basically, nerve damage that causes numbness and tingling in the fingers and toes. So the best way, and for this your particular situation, the person who asked this probably won't be that helpful, but the best thing is prevention. So I think clear communication with your provider team when you develop neuropathy with myeloma treatment, because doses need to be reduced or spread out. Because prevention, an ounce of prevention is worth a pound of cure in this case with neuropathy. And so we try to adapt our therapies to prevent that. If the neuropathy has already developed, then we typically use Cymbalta, which was originally formulated as an antidepressant or anti-anxiety medication, but also helps with neuropathy. And so we also use other agents that can act on neurotransmitters like gabapentin or Lyrica, which is pregabalin. And so we use those medications to try to help with the neuropathy. Although sometimes and time, right, time off treatment that caused the neuropathy can also help to heal some of that damage. And we do see improvement when we hold therapy. And so I would say those are the things that are typically in my arsenal for treating neuropathy.
Perfect. Thank you. And I think the other comments were, does multiple myeloma spread? And who's at risk to get myeloma?
Right. Can myeloma be in other parts of the body? So it can. And so we talked about bone lesions a lot, and that is one of the myeloma defining events, but it can be elsewhere in the body. So when I think about myeloma, kind of the solid part of myeloma or tumors related to myeloma, bones are the most common place where those can show up. But there are a subset of patients who develop myeloma elsewhere outside the bones. We call that extramedullary disease. That can be disease that turns up in the body, the organs. It can show up in the skin and soft tissue, which is common. It can, in very rare cases, go to the CNS, although that's very uncommon with myeloma. And so when we do our initial studies, I like to do a PET scan or an MRI because that can also identify tumors elsewhere in the body. It's important in the newly diagnosed setting that even if a patient has myeloma and has a tumor, we often will biopsy the tumor as well, just to make sure we're not missing some other kind of primary malignancy, since it's not usually that common for it to present up front that way. Later on, when patients relapse, it's more common for it to sort of turn into extramedullary disease or disease outside the bones. And so that's something we have to monitor closely after we treat patients. Because extramedullary disease tends to come with a more aggressive behavior. And so it tends to be more difficult to treat. So that's something that we keep a close eye on. And then the last question was about
Who's at risk for getting multiple
Oh,
myeloma?
who's at risk? Yeah. So as we talked about, myeloma is most common in patients in their 60s. So the median age at diagnosis is 69. So we don't typically see it in pediatric populations, although we do see it as in patients as young as in their 30s. But usually it's patients in their 60s and 70s. That's the most common age of diagnosis. And so those patients are at highest risk, older patients who have had maybe this precursor conditions that have now evolved into myeloma. African Americans are more likely to develop myeloma than Caucasians, so 2 times more likely. So it's enriched in the Black or African American population. And men are slightly more likely to develop myeloma than women. But again, we have a broad range of patients who come in. So there's not one particular population that's specifically at risk.
Okay, perfect. And we are actually almost at time, so I think there's room for one more question, which is a very interesting question, and I wanted to open up to any and all of you speakers. When is it a good time to have your case discussed in a tumor board? Very general question. Do you guys have any thoughts about that? I'll start. So, I think that maybe taking a step back about what this question is, what a tumor board is really an opinion from a group of physicians. And you could consider it as a second opinion in some sense. So I think it's always an okay idea to have your case reviewed as a second opinion from a consultation from a different institution. I always recommend second opinions for my patients so that they feel confident in, number one, their diagnosis and treatment plans. Also, they may have preferences that a different institution may align with. So in my opinion, the heart of this question may be about second opinions. I always welcome it. In terms of tumor board, I think it's very challenging from a patient's perspective to either join a tumor board or contribute their patient case to a tumor board. These are typically physician run and a confidential discussion between specialists so that they can understand the context very quickly and talk about treatment decisions as a multidisciplinary group. I think it's always okay to ask your physician if you think your case is appropriate for a tumor board if one tumor board exists at that institution. But it's hard to prescribe a single instance or a single paradigm that says this is the type that goes to a tumor board. That's my opinion.
Yeah, great, thanks. And that's what I usually do, is that usually your physician determines when the case needs to be presented on tumor board. I usually present it when I'm not certain about the diagnosis. So I don't know if you guys know how our workflow goes, right? Like when I get a consultation, they send me a piece of paper with pathology diagnosis on the top, and then what are the stain they do. So sometimes when you look at the stain, you're a little confused in terms of, the patient's clinical presentation does not match the diagnosis. Then you have a tumor board where your pathologist shows you the slides, the radiologist shows the PET scan, everybody look at it, and then we'll hopefully reach to a diagnosis. If we don't reach a diagnosis, we can talk about what tests we do. And then like Andrew said, it's kind of like tumor board has all the physicians with that department that joins, or all the lymphoma doctors at Moffitt. So I can ask my mentor or other doctors, well, what would you do in this case? And you also have radiation oncologists, and then also our beautiful, amazing BMT doctors. So a lot of case we'll talk about allo, right? For us, we're like, oh, patient goes to allo because, we get a cure, this and that. But your transplant doctor might say, oh, the risk of allo is too high. Is heart issues or this issues or a lot of issues that lymphoma doctor don't think of. Sometimes there might be even a debate, but eventually we reach to a consensus of what we want to do because we want to hear each other's opinion. Yeah.
Great. Thank you so much, Dr. Zhang. So with that, I think we will go ahead and conclude with the webinar. Thank you so much to everybody attending in the audience to the 2025 Cancer Grace Blood Cancers OncTalk live webinar. I'm very, very gracious to our amazing speakers. Again, they are Dr. Ashwin Kishtagari from Vanderbilt, Dr. Jennifer Cooperrider from University of Chicago, Dr. Julia Zhang from Moffitt Cancer Center, and Dr. Amar Kelkar from Dana-Farber Cancer Institute. I also want to thank our sponsors without which this wouldn't be possible. They are Lilly Oncology, AbbVie, and Bristol Myers Squibb. I ask you all in the audience, please, please, please give us your feedback about today's session. You'll be able to find the post-event feedback questionnaire. I believe it's at the bottom of your current screen, and you will also receive a post-event email for which there will be a link to give us your feedback as well. We're always looking to improve. And with that, I'll ask the speakers to stay on for a little bit longer, but thank you so much for attending. We will conclude at this time. Take care.